Chapter 7, Children with Attention Deficit Hyperactivity Disorders, or ADHD. Historically, until the late 1700s, there was a medical model for ADHD, and this focused on patients unusually fidgety and inattentive and unruly. After the encephalitis epidemic, which happened in 1917 to 1918, which results from acute brain inflammation, the same symptoms were called minimum brain damage. Soldiers after World War II were categorized with having traumatic brain injury, and these soldiers had similar symptoms plus disorganization. And Strauss syndrome was coined in the 1930s to describe these symptoms. And Cruikshank was one of the first to develop educational strategies for these students. So Strauss syndrome, we can see here in figure 7.1, includes these symptoms: erratic and inappropriate behavior on mild provocation, increased motor activity, distractibility of a more than ordinary degree under ordinary conditions, persistent hyperactivity, awkwardness and consistently poor motor performance, and persistent faulty perceptions, and poor organization of behavior. So these sound more like our current definition of ADHD. So then, looking at the characteristics of children with ADHD, the symptoms, and this comes from the Diagnostic and Statistical Manual, the 5th edition. So in some of the characteristics of inattention would be fails to give close attention to details or makes careless mistakes in schoolwork and other activities, does not seem to listen when spoken to directly, avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort like homework, is forgetful in daily activities. Hyperactivity, some of the symptoms would be leave seat in the classroom or in other situations in which remaining seated is expected, has difficulty playing and engaging in leisure activities quietly, talks excessively, impulsivity, has difficulty waiting their turn, interrupts or intrudes on others, butts into conversations or games. So those are some of the characteristics of the inattention, hyperactivity, and impulsivity related to ADHD. So when we look at our information processing model, we can see that the primary effect is executive function, and secondary effects in regards to attention would be information input from what they see and hear. If they're not paying attention, that's difficult. Thinking and processing, it affects all areas. Secondarily, memory, classification, association, reasoning, and evaluation. And then in regards to response, it affects writing and social interactions. So then a more current definition of ADHD, IDEA 2004 includes ADHD under other health impairments. The Diagnostic and Statistical Manual number 5 includes ADHD in the cluster of neurodevelopmental disorders, and children with other disabilities often have ADHD as well, and that's called comorbidity. So identifying students with ADHD, Students may receive services under IDEA 2004 or Section 504 of the Rehabilitation Act. And so that might happen through the process of carrying out cognitive and academic tests. Only about 1% of students have severe enough impairments to qualify for special services. And so something to keep in mind is that unless a child has other issues in regards to having special needs, ADHD by itself, as it mentioned, is not considered severe enough to require services. And so one of the things that can happen, though, if an IEP is not something that they have been able to be assessed to have, then Section 504 of the Rehabilitation Act, which has to do with those veterans that we mentioned in the first slide, we can utilize that 504 to require accommodations within the classroom. It's not an IEP, but it can be helpful in helping children pay attention in class and get the accommodations or the special arrangements that can help them pay attention in class. Parent and teacher input is a valuable part of the identification process and is collected using rating scales such as the Conners 3, where they rate how often symptoms might appear. It may be accurate for students from, it may not be accurate for students from diverse backgrounds. Boys are 2 to 3 times more likely to be identified as having ADHD than girls. So some causes of ADHD. It's caused by a complex interplay of genetics, neurology, and the environment. When we look at neurology, studies have shown differences in the brains of individuals with ADHD, including the size, development rate, and structures of the brain. Genetically, it tends to run in families. Studies are attempting to identify the specific genes that are involved. Environment, it could come from exposure to certain substances. It can be caused by premature birth, and brain damage or injury can increase the risks for ADHD. So comorbidity, and that just means that it exists with other special needs. Between 40 and 60% of children with ADHD have an additional area of concern. Almost a third of children with ADHD also have a learning disability. Emotional and behavioral disorders, communication disorders, and mental health concerns are all frequently comorbid with ADHD. So medication for ADHD. About 66% of all children with ADHD receive medication as part of their treatment. Medication usage must be carefully monitored to watch for potentially harmful side effects. And those side effects include it disturbs their appetite, it disturbs their hydration levels, and their sleep. And nutrition, sleep, and hydration are an important part of growth and development, and so it needs to be very closely monitored and only be used as a last-ditch effort. Other approaches should be used first. Stimulants are the most common class of medication used, and with stimulants, this increases the neurotransmitter production, which enhances a child's ability for attention and controlling their impulse. And so you might think that stimulants are the most common class of medication. You might think that that would make them worse and more active, but it actually has a different effect on an individual with ADHD than it would on an individual without those symptoms. So when we look at how we provide services, we want to use a multimodal support approach where we are using pharmacological medical support, behavioral therapies, and academic interventions. And from my work with children with special needs, I would say the pharmacological for a last result. Although research does show that the three together has the most effective impact. Teachers must address both academic and behavioral needs in planning their instruction for students with ADHD, and they should identify the strengths and needs of the child, select appropriate instructional approaches, and then implement these consistently, and make sure that they're not penalizing a child because of their special need. And that can be one of the problems with behavioral issues is we often blame a child because they have behavioral issues when really that's their special need and we're supposed to facilitate and support them. So here we have some examples of different kinds of learning strategies that can be used, focusing on time, such as extending time on assignments, support within peer groups, having a study buddy, assistive technology we mentioned previously, complexity, use big ideas to help organize smaller ideas, the structure of how things are presented, it's the process, the environment, and the context. And so these are a long list of different kinds of strategies that can help provide accommodations for children with ADHD. So some evidence-based interventions that have been very effective is behavior modification. So focus on appropriate behavior and reinforce that with something the child likes with positive reinforcement. As a child gets older, creating behavioral contracts that they help create and then adjusting those as needed. In instructional management, arrange the environment so it's easier for a child to focus, provide timely feedback, and monitor progress regularly. With organizational strategies, organize their papers and supplies so they can keep track of things. Develop routines and checklists to help them stay on track. Help develop self-regulation approaches, monitoring, and directed learning. Offer them choices rather than always telling them. Have signals to cue them where they don't have to be directly addressed by the teacher, like having the teacher pull on their earlobe to remind a child to stay on task rather than saying their name over and over. And then allowing them opportunities to move so that they can get some of those needs met. So the role of families play an important role in interventions for children with ADHD. They really need to be on board and support and work in collaboration with the school. Family stressors such as poverty or unsafe living conditions can, of course, make things worse when it comes to ADHD. Training programs that offer strategies to parents for supporting their child have shown success in reducing family stress and increasing their confidence in their ability to deal effectively with the issues related to their child's ADHD. So when we talk about transitions, students with ADHD are at a higher risk than peers of continued academic and social difficulties, substance abuse problems, and delinquent behavior. And one of the issues with substance abuse for any individual with special needs is that it's a way that they can self-medicate. And so as we consider the benefits and disadvantages of medication, we need to think about that if things are not working out for an individual, they might turn to substance abuse to self-medicate. With strong supports and interventions during school, students with ADHD can develop coping skills that will allow them to go on to academic and social and career success. And this is something to keep in mind in regards to medication, because it doesn't really solve the problem. And what really is most effective is helping the individual come up with skills, coping skills, and skills that they can use to deal with the issues that come along with ADHD, rather than just controlling it with medication.